Go ahead, ma. Sorry.
My topic for today is modes of mechanical ventilation in ICU. Operating modes of mechanical ventilation. A ventilator mode can be defined as a set of operating characteristics that control how the ventilator functions. There are various modes of mechanical ventilation, nearly 23. First is spontaneous ventilation. The ventilator simply provides the flow and the supplemental oxygen. Here, the role of the ventilator is in spontaneous mode is to provide the inspiratory flow to the patient in a timely manner, flow adequate to fulfill the patient's inspiratory demand, and adjunctive modes such as PEEP to complement a patient's spontaneous breathing effort. Apnea ventilation. In event of apnea or extremely low frequency, a backup ventilation is invoked by the apnea ventilation feature, and it delivers a predetermined tidal volume, frequencies, FiO2s, and other ventilator functions to the patient. Positive end expiratory pressure, PEEP. It is a airway pressure strategy in ventilation that increases the end expiratory or baseline airway pressure to a value greater than the atmospheric pressure. It is used to treat the refractory hypoxemia caused by intrapulmonary shunting. Physiology of PEEP includes PEEP decreases the pressure threshold for the alveolar inflation, which increases the FRC, therefore improves ventilation and increases the ventilation perfusion matching, which then improves oxygenation and decreases the work of breathing. The complication of PEEP includes decreased venous return, barotrauma, increased intracranial pressure, and alteration of the renal functions due to hypoperfusion. CPAP, continuous positive airway pressure ventilation. It is a PEEP applied to the airway of a patient who is breathing spontaneously. In adults, CPAP may be given via face mask, nasal mask, or endotracheal tube. In neonates, nasal CPAP is the preferred mode of choice. Indications of PEEP or CPAP includes intrapulmonary shunt or refractory hypoxemia, decreased FRC and lung compliance, auto PEEP which is not responding to any adjustment in the ventilator settings. For CPAP, the patient must have adequate lung functions that sustain eucapnic ventilation. Eucapnic ventilation is the amount of ventilation that is needed to bring the patient's PaCO2 to normal level. Then bilevel positive airway pressure, BiPAP. The BiPAP allows the clinician to apply independent positive airway pressure during both inspiration and expiration. Inspiratory PAP, IPAP, and expiratory PAP, EPAP. The inspiratory PAP, IPAP provides positive pressure breaths and it improves the ventilation and hypoxemia due to hypoventilation. Expiratory PAP is a SNCPAP and it improves oxygenation by increasing the FRC and reducing the intrapulmonary shunting. Indication of BiPAP. It is useful in preventing intubation of the chronic obstructive pulmonary disease patients, and in initial settings of IPAP and EPAP are 8 centimeter of water and 4 centimeter of water respectively. The BiPAP device can be used as a CPAP device by setting the IPAP and the EPAP at the same level. Controlled mandatory ventilation. It is also known as continuous mandatory ventilation or a control mode. Here, the ventilator delivers a preset tidal volume at a time triggered frequency. The type of breath which is delivered is each breath delivers a mechanical tidal volume, and the triggering mechanism is time triggered. Cycling mechanism is inspiration is terminated by the delivery of the preset tidal volume. It should be used when the patients are medicated with sedatives, respiratory depressants, and neuromuscular blockers. The indications of controlled mechanical ventilations are patients fighting the initial stages of the mechanical ventilatory support, tetanus or other seizure activities that interrupt the delivery of a mechanical ventilation, complete rest for the patient, typically for the period of 24 hours. These are the patients that need controlled mandatory ventilation. The complication of controlled mandatory ventilation is in a sedated or apneic patient, there is a potential for apnea and hypoxia if the patient should become disconnected from the ventilator or the ventilator fail to operate. Assist control. With the assist control mode, the patient may increase the frequency assist in addition to the preset mechanical frequency control. Each control breath provides a patient with the preset ventilator derived tidal volume. In The type of breath delivered is each breath with is assist or a control which delivers a preset mechanical tidal volume. The triggering mechanism may be patient triggered, which gives a assist breath, or a time triggered, which gives a control breath. Cycling mechanism. The inspiration is terminated either by the delivery of a preset tidal volume cycle, or by the high pressure limit, which is pressure cycle. The advantages of the assist control mode is the patient work of breathing requirement in the is very small, and when the triggering sensitivity is set appropriately, and the ventilator supplies an inspiratory flow that meets or exceeds the patient's inspiratory flow demand. If the patient has appropriate ventilatory drive, this mode allows the patient to control the frequency and the mechanical minute volume to normalize the patient's PaCO2. The complication of assist control mode is alveolar hyperventilation. Intermittent mandatory ventilation. In intermittent mandatory ventilation, the ventilator delivers the mandatory breath and allows the patient to breathe spontaneously at any tidal volume. The patient is capable of in between mandatory breaths. Since the intermittent mandatory breaths are delivered at a frequency independent of the patient's spontaneous frequency, breath stacking may occur. So, synchronized intermittent mandatory ventilation is now used. Which is a SIMV mode. Here, the ventilator delivers either assisted breaths to the patient at the beginning of a spontaneous breath, or time-triggered mandatory breaths. The mandatory breaths are synchronized with the patient's spontaneous breathing effort so as to avoid breath stacking. The type of breath. The ventilator delivers mechanical tidal volume at a preset frequency. The patient may breathe spontaneously between the mandatory breaths. Triggering mechanism may be either time triggered or patient triggered. Cycling mechanism. The mandatory breaths are volume cycle, and the patient controls the spontaneous frequency and the volume. The indication of SIMV mode. It provides partial ventilatory support to the patient. The advantages are it maintains a respiratory muscle strength and avoids muscle atrophy, reduces ventilation perfusion mismatch, decreases the mean airway pressure, and facilitates weaning. Complications. The desire to wean the patient too rapidly, leading to high work of spontaneous breathing, and ultimately leading to muscle fatigue, and weaning failure can occur. Mandatory minute ventilation. Mandatory minute ventilation causes an increase of mandatory frequency when the patient's spontaneous breathing level becomes inadequate. This compensation by the ventilator ensures a safe minimal minute ventilation. The type of breath. If the ventilator increases the mandatory frequency, the triggering mechanism. Increases of mandatory frequency is triggered when the actual minute volume is less than the preset minimal minute volume. Cycling mechanism. All mandatory breaths are volume cycle. Patient control their own spontaneous frequency and volume. Pressure support ventilation. Pressure support ventilation applies a preset pressure plateau to the patient's airway for the duration of a spontaneous breath. The pressure supported breaths are spontaneous because patient triggered, and the tidal volume varies with the patient's inspiratory flow demand. Inspiration lasts only for as long as the patient actively inspires. Inspiration is terminated when the patient inspiratory flow demand decreases to a preset minimal value. Indications of a pressure support ventilation along with SIMV to facilitate weaning in a difficult to wean patient. In a pressure support increases the patient's spontaneous tidal volume, increases patient's spontaneous frequency, and decreases the work of breathing. The type of breath is pressure supported breath and are considered spontaneous. Triggering mechanism is patient triggered, and cycling mechanism is flow cycled by a minimum spontaneous inspiratory flow threshold, and the minimum inspiratory flow is controlled entirely by the patient's spontaneous inspiratory flow demand. And adaptive support ventilation. Adaptive support ventilation is a dual control mode that provides a mandatory minute ventilation, a mode of ventilation that changes the number of mandatory breaths and the support level according to the patient's breathing pattern. Proportional assist ventilation, a mode that uses variable pressure to provide pressure support. The variable pressure is in proportion to the patient's pulmonary characteristics and demand. Proportional assist ventilation may be of two types: flow assist and volume assist. In flow assist, the applied pressure is provided to meet the patient's inspiratory flow demand. In flow assist, reduces the inspiratory effort needed to overcome the airflow resistance. In volume assist occurs when proportional assist ventilation provides the pressure to meet the patient's volume requirement. Type of breath: proportional assist ventilation occurs during assisted breaths only. Triggering mechanism is either pressure or flow trigger. Cycling mechanism: it terminates once the patient's volume or flow demand is met. Volume assured pressure support: a mode of ventilation that assures a stable tidal volume by incorporating inspirative pressure support ventilation with conventional volume assisted ventilation cycles. It provides an optimal inspiratory flow during assisted or controlled cycles, then reducing the patient's work of breathing. Unlike the typical pressure support, volume assured pressure support assures a stable tidal volume in patients with irregular breathing patterns. In volume assured pressure support, the mechanical breaths may be patient or time triggered. Once a breath is triggered, the ventilator tries to reach the pressure support level as soon as possible. Then the delivered volume is then compared to the preset tidal volume for further action by the ventilator. The volume assured pressure support may prolong the inspiratory time. Patients with the airflow obstruction should be monitored closely in order to prevent air trapping. Pressure regulated volume control PRVC mode, a mode of ventilation that provides volume control breath with the lowest pressure possible by altering the flow and the inspiratory time. The PRVC provides volume support while keeping a peak inspiratory pressure at the lowest level possible. Type of breath: control in Siemens 300 ventilator and SIMV in other ventilators. Triggering mechanism: time triggered or patient triggered. Cycling mechanism: volume cycled under normal operating conditions. Adaptive pressure control APC, a mode of pressure control breath that utilizes the control loop control of the pressure setting to maintain a minimum delivered tidal volume. Since the inflation pressure is variable, as the patient's inspiratory effort increases, the inflation pressure is reduced. Volume ventilation plus, a mode that combines a volume control plus and volume support. Volume control plus is used to deliver mandatory breaths during SIMV modes of ventilation and assist control modes of ventilation. It is intended to provide a high level of synchrony than a standard volume control ventilation. Volume support: it is intended to provide controlled tidal volume and increase patient comfort. In volume support, clinician sets the target tidal volume and the ventilator uses a variable pressure support levels to provide the target tidal volume. During ventilator support, the ventilator frequency and the minute ventilation are determined by the triggering effort of the patient. The inspiratory time is determined by the patient respiratory demand. Pressure control ventilation. A pressure plateau is created at the beginning of the inspiration and the pressure is maintained for a preset inspiratory time. The pressure control ventilation can minimize the airway pressures while providing the support to oxygenation and ventilation. Type of breath is: only mandatory breaths are available to the patient and in the pressure control mode. Triggering mechanism: the breaths are time triggered, and the cycling mechanism: time cycled by a preset inspiratory time. Airway pressure release ventilation. It uses the airway pressure release ventilation consists of two CPAP or pressure levels, whereas high pressure, pressure high or pressure inspiratory level, low pressure or low or PEEP. Mode of ventilation in which the spontaneous breaths are at an elevated baseline. This elevated baseline is periodically released to facilitate the expiration. The patient is allowed to breathe spontaneously without restriction. The type of breath is time triggered and the time triggered mandatory breaths. The patient is allowed to breathe spontaneously between the mandatory breaths. The triggering mechanism is time triggered. Cycling: the mandatory breaths are time cycled by a preset inspiratory time. The APRV is indicated in ARDS. Inverse ratio
Finished out
ventilation.
of 23.
Yes, sir. Three more, sir.
3 more. Complete it.
Yes.
Okay.
Inverse ratio ventilation. The inverse ratio ventilation is a ratio of the inspiratory time to the expiratory term is known as inspiratory expiratory ratio. This inspiratory expiratory ratio, inverse ratio ventilation is done between 2:1 and 4:1 and often in conjunction with the pressure control ventilation. It improves the oxygenation by reduction of the intrapulmonary shunting, improvement of ventilation perfusion matching, and decrease of the desk space ventilation. During inverse ratio ventilation, that is increased mean airway pressure, increased central venous pressure and pulmonary arterial pressure, that is decreased PEEP requirement, decreased peak airway pressure and decreased cardiac output. The types of inverse ratio ventilation include volume control inverse ratio ventilation and pressure control inverse ratio ventilation. In pressure control, a constant pressure is applied for the duration of the inspiration. Neurally adjusted ventilator assist NAVA. It is a new mode in which the mechanical ventilation, the patient's electrical activity of the diaphragm guides the optimal functions of the ventilator. The neural controls of respiration originated from the patient's respiratory center are sent to the diaphragm via the phrenic nerves. The bipolar electrodes are used to pick up the electrical activity. These electrodes are mounted on a esophagus at the level of the diaphragm. It is used in the management of weaning the patients with spinal cord injury, head injury, COPD, and the patients with a history of ventilator dependency. High frequency oscillatory ventilation. It uses very high frequency rates and a very low tidal volume to deliver small oscillations around a fixed mean airway pressure. It maintains the lung recruitment with a constant mean airway pressure. Gas exchange occurs through mechanism like bulk flow, diffusion, and molecular mixing. It is indicated in severe ARDS and neonatal and pediatric respiratory distress. It minimizes barotrauma and volute trauma by avoiding the large tidal volumes. Disadvantages, it requires some sedation and paralysis.
Very good. I appreciate your patience in preparing such a long list of modes of ventilation and then talking it with a lot of effort.
Thank you, sir.
But the basic thing all of you have to understand is why mechanical ventilation is needed. What is the reason for introducing mechanical ventilation as a strategy in ICU or critical care units?
To provide assistance when the patient is not able to breathe.
Breathe. As simple as logically correct thinking. When patient is not able to oxygenate himself by his own spontaneous breathing, he requires an assistance which is provided by mechanical ventilation. Okay. Why anesthetists became the pioneers in mechanical ventilation? It was anesthetists who introduced mechanical ventilation into ICU and critical areas. Why is that?
Under anesthesia, ventilation is in our control, sir. So.
Excellent, fantastic. And when the muscle relaxants were introduced, until the time muscle relaxants were not in clinical use, patients were allowed to breathe spontaneously, inhaling the inhalation agents starting from chloroform, diethyl ether, and ethylene oxide, and all those things. I mean, ethyl chloride, all these things were poured onto the patient's face or delivered through a face mask, and spontaneous respiration was maintained throughout the surgery. And patient was kept unconscious by his own spontaneous effort breathing these inhalation agents. But in 1950, when tubercularine was introduced by Cecil Gray and his colleagues into preclinical practice, it's dramatically changed the pattern of anesthesia. We brought in what is called controlled ventilation. We paralyzed the patient, we intubated them with an endotracheal tube, and throughout the entire duration of surgery, we kept them paralyzed by not allowing them to breathe, and we managed their ventilation by squeezing the bag and pumping the gases into the patient's lung. Okay. This was done mechanically by hands of the assistant anesthesiologist by squeezing the reservoir bag. Later on, ventilators, anesthesia ventilators with bellows were introduced, which did the function of the anesthetics by squeezing the bag. Okay. So because of this experience, this was extrapolated to the use in ICU and critical care, where patients, because of some pathological conditions, came in a state of inability to maintain their oxygenation or eliminate the carbon dioxide, which condition is called type 1 or type 2 respiratory failure, which needed prolonged hours of support. So for that, they have to do the mechanical ventilation. Okay, this is the basis of mechanical ventilation. So the purpose of mechanical ventilation is to maintain proper oxygenation in the patient, at the same time eliminate carbon dioxide and keep normocapnia. This is the purpose. This can be achieved by delivering a set tidal volume to the patient. Whenever an emergency patient comes to you, these 3 years worked in ICU and put the patients on ventilator and manage them, isn't it? So what are all the parameters you want to set before you start ventilating a patient mechanically with a ventilator in ICU? What are all the parameters you will go and set in the ventilator that you are going to use?
FiO2,
Okay,
tidal volume,
very good.
respiratory rate,
Great.
and pressure support or PEEP.
Okay. You want to set the IE ratio, inspiration to expiration ratio. Okay, and then flow rate, peak flow rate. All these parameters have to be set so that the set tidal volume will be delivered and the minute ventilation will be supplied to the patient. Okay, this is the parameter. So this can be done by what is called volume cycle or volume delivered mode of ventilation, where despite the fact whatever be the changes in the patient, if you set 500 ml tidal volume, come what may, that 500 ml will be delivered to the patient. This is called volume controlled ventilation. The other mode is called pressure controlled ventilation, where at a particular pressure, the gas will be delivered to the patient, but the volume will not be guaranteed. If you set 500 at one time, it may deliver 600 or 650. Another time, it may deliver just 350, depending upon two factors. What are the two factors which are going to govern the delivery of gases to the patient or air to the patient?
Airway resistance, sir.
Airway resistance and compliance of the alveoli and chest wall. Okay, these are the two basic things which you have to remember. One is the airway resistance, second is the compliance. If the resistance increases, even when you set a volume delivering mode or volume control mode, if the airway becomes, there is a bronchospasm, all the airways become narrow, will the volume be delivered?
No, sir.
No. So there you require a pressure support or a pressure control ventilation. Okay. So you must analyze the patient's lung condition, whether it is a nicely dilated, well compliant lung, then you can put the patient on volume control ventilation. On the contrary, an asthmatic, a patient with increased airway resistance, and a COPD patient with less compliance, then you have to put them on pressure control ventilation. So that first decision you have to make is whether we are going to do a volume control ventilation or a pressure control ventilation. Whenever there is likely to be increased resistance, then you have to apply more pressure to deliver the gases, despite whether you achieve the set tidal volume or not, the gas has to be somehow delivered at the alveolar level. Whereas if the airway passage is quite normal and compliance is normal, setting a volume control will deliver the required tidal volume to the patient. So these are the two basic modes. Apart from that, you cannot be endlessly taking time to deliver the volume. So there is also an element of time element is there, because in normal respiratory pattern, when we breathe at 20 breaths per minute in normal physiology, that means for 60 seconds we are breathing 20 times, which means for each breath we are spending 3 seconds for our normal breath. 20 into 3 is 60 seconds, 1 minute. So for a minute, if a person is going to breathe 20 times, we are having 3 seconds for a complete cycle of inspiration and expiration, out of which the inspiration is supposed to be 1 second and the expiration is supposed to be 2 seconds, with a total of 3 seconds, making one single breath. So the same pattern has to be applied to the mechanical ventilation also, where you set the IE ratio at 1:2. That is one part or one time for 1 second for inspiration and 2 seconds for expiration. But there are conditions where expiration may be blocked or expiration may be more resistant to exhale the gases. In such situations, either you have to give more time for exhalation, so you increase the exhalation period to 1:3 or 1:4, like in cases of severe bronchospasm. And that is how you adjust this. So these are the basic principles that you have to keep in mind, and based on that only you have the volume control, pressure control, assist control, which is a mechanism where you can incorporate both volume or assist. And then once the patient initially, when he is totally apneic, he is under full control, like when we intubate a patient with the intubating dose of muscle relaxant, he is totally paralyzed. You put the tube and then you take over the ventilation. Whatever rate you want to squeeze the bag and keep the respiratory rate, we can do that. But once he comes out of the muscle relaxant effect and starts breathing, if you don't match his spontaneous efforts, what will happen? You will be squeezing at one particular rate and he will be having a respiratory rate at a different number. So these two will not go together unless you do it synchronously with his respiration, and there will be a situation what is called fighting the ventilator, isn't it? So in order to do that, they introduced a mode called synchronized intermittent mandatory ventilation, where patient has some effect, but which is not sufficient enough. The muscle power is not good enough to maintain oxygenation and elimination of CO2. So the machine will at the time only assist the ventilation. So SIMV mode was introduced, and in the SIMV mode, in order to safeguard that supposing patient after taking 4 breaths becomes apneic again, and the machine is waiting for the patient breath and not delivering until he starts breathing, there will be a long apneic period, patient will likely to desaturate. So to avoid that situation, after a particular interval, if the patient is not triggering or if he is not making an inspiratory effort, machine will start delivering a breath on its own at the preset time volume. This is called the mandatory breath. That is why it is called synchronized intermittent mandatory breath. This mandatory breath is important to prevent any apneic spells that is happening in the patient who is just recovering with not adequate muscle power to breathe on his own completely spontaneously. Okay, so this was once later on when the patient gets more power and it is time to take him off the ventilator, you cannot abruptly disconnect after ventilating for 3 days or 4 days. You cannot just like that disconnect and take the tube out and make him breathe spontaneously. During that time, the machine will be watching the patient's effort, and whenever there is an inadequate effort, machine will come and deliver a extra support. That was called the pressure support ventilation. Okay, so this support came whenever the triggering effort was much less compared to the set level, and that helped in the patient maintaining the saturation, maintaining the oxygenation. At the same time, helped him get more energy to breathe and helped in the weaning process also. Okay, so this is the basis of any mechanical ventilation, and all the later modifications like APRV, PVC, the 23 things out of which are at least except the 5, 6, 18 to 17 modes of ventilation are all simple modifications of the basic modes of ventilation. So once you understand that, then the understanding of the newer modes of ventilation. So sometimes they ask in the theory examination, newer modes of mechanical ventilation. In that only the last 5 or 6 what you have mentioned, except the HFNO, all those things neurally assisted, airway pressure release, ventilation. All those things are just modifications of the basic volume control or pressure control and assist control modes of ventilation. Okay. So to understand that, I'll just go ahead with a small presentation to show you how to remember those points. Is it visible now?
Yes, sir.
Yes, sir.
So modes of mechanical ventilation, some of the modes, if you make this tabular column, this is much easy to remember. The control modes can be volume cycle, pressure release volume cycle, and non-invasive pressure control. The support modes are, that is when patient starts breathing, but the attempts are all the time not fully strong enough to breathe. Then you go for pressure support, volume support, or NIV pressure support. The combined modes, once they go into the auto mode, it can be VC, VS, or pressure control, pressure support. It can be PRVC, SAMV with volume control, PS, etc. And once the patient has a spontaneous respiration, but it is slightly inadequate or it is partly obstructed, then you can think of CPAP or nasal PAP. Okay? But for this, patient should have consciousness level in the normal setting. Whereas if the patient is sedated or unconsciousness is present, then these are the modes that should be chosen. And this is mainly only for conscious patient with inadequate respiration, whom the attempts are good but inadequate. You can go for this particular mode of ventilation. So coming to each and every mode, the pressure control ventilation, the ventilator will deliver a breath at a pressure and a preset pressure and rate. This mode in patients who are not having a spontaneous respiration. So this is mainly for patients who are apneic or totally paralyzed, and it will be switching over to supporting the spontaneous ventilation once the patient starts triggering the ventilator. Until then, it is mainly for patients who are initially sedated, who are fighting the ventilator. You give them heavy sedation and start ventilating them. This is the mode that we commonly use. Then volume control ventilation. Here the tidal volume will have to be delivered. At a preset delivered volume will be delivered when patient again has got no spontaneous respiration. And peak airway pressure will vary. Here the tidal volume delivered will vary because of the changes in the pressure. Whereas here the airway pressure will vary depending upon the compliance and resistance of the patient. And pressure regulated volume control mode is nothing but a combination of pressure control and VC control, where the tidal volume is delivered at the lowest possible pressure. So because of the drawbacks in these two modes of ventilation, here when you set it at pressure control, the volume is not guaranteed. The tidal volume delivery is not guaranteed. It is once the pressure is reached, it will abruptly stop delivering further tidal volume. Here, whatever be the pressure rise, it will deliver the tidal volume, but the pressure sometimes can go enormously high to cause barotrauma. So to overcome these two, they have incorporated these two modes of ventilation, which is called pressure regulated volume control mode, where it will automatically adjust the pressure as well as the tidal volume so that the entire tidal volume delivered without causing barotrauma. That is the advantage of PRVC. Now, if the upper limit of airway pressure is reached, this mode will switch over to expiration and prevent barotrauma, but the set volume will not be delivered completely to some extent, but most of the time it will be delivered if the patient's airways are quite clear. What is this auto mode? All the above three modes have the ability to switch from control mode, that is ventilator triggering breath, to support mode, that patient triggering breath with spontaneous effort. So when you set it in auto mode, automatically this will switch over to that. Now SIMV is the mode which is used when patient has spontaneous breathing, but the efforts are not totally adequate. At the time, to prevent the patient fighting the ventilator, the machine will synchronize, sensing the inspiratory effort of the patient. It will get triggered and immediately it will coincide with the inspiratory time and they deliver the tidal volume, so that it will be like a normal assisted ventilation. And ventilator provides mandatory breaths which are synchronized with patient's spontaneous effort at the preset rate, so that there is no long period of apnea and desaturation happening because patient is not triggering the ventilator. And there are three SIMV modes which include pressure support, and these are called SIMV with volume control, SIM with pressure control, SIM with PRVC. So what we saw earlier in the earlier slide, all the three modes can be incorporated with synchronized intermittent mandatory ventilation also. Now coming to pressure support ventilation, this mode supports every patient breath and used mainly in weaning from ventilator. And volume support ventilation, this is similar to pressure support, but it supports more volume delivery than the pressure required to complete the respiration. Now CPAP, when PEEP is applied without other forms of ventilation, it is called CPAP. That is no pressure support, no volume support. Here the dependence is mainly on patient's own spontaneous respiration, where some amount of pressure is applied to the airway continuously, both during inspiration and expiration. And BiPAP is one where you give a higher inspiratory pressure and a lesser expiratory pressure, so that patient can breathe out easily. Whereas in CPAP, it is a set pressure of 4 to 7 centimeters all the time. So some patients will find it difficult to breathe out because there is a positive pressure even during expiration, even though that is going to help in keeping the alveoli open. If the patient is not tolerating a CPAP, he has to be converted into BiPAP, where we can have a lesser pressure exhibited during the expiratory time. So which ventilation mode for which treatment phase, that is which part of respiratory phase, this picture will give you a good idea. So starting from here, when patient is not having any respiratory attempt at all, respiratory muscles are intact and or paralyzed, and breathing controls are not available. Patient is either sedated or there is a trauma, there is a neurological problem. In that situation, we start with controlled ventilation, and you can see the whole circle is dark colored. Now, once the patient muscles recover, respiratory muscles are improving, but they are weak, and the breathing controls are restricted or unstable, then you go for partial support, that is called mixed ventilation. And once patient's effort muscles are still weak, but breathing control has been established and he is trying to breathe spontaneously, then you go for assisted spontaneous breathing. And once the patient's muscle power is quite sufficient and he gets back all the breathing system controls, then you allow him to breathe spontaneously and do a spontaneous breathing trial, and then try to extubate the patient. So you can see the circle from just like a moon become waxing and waning. You have a dark circle, 3/4, then 1/4, then completely clear. So control mode to mixed ventilation to assisted ventilation to spontaneous ventilation. These are the normally 4 phases in any patient's mechanical ventilation that you will require to help. So in control mode, this is entirely under control. Whatever settings you give, whether you give volume cycle or pressure cycle, depending upon the patient's airway and compliance, it is all in your hands. When he starts breathing, actually you go for mixed ventilation. Here it will be requiring more support and less spontaneous effort. Then the power improves and you support every breath of the patient to bring him back to spontaneous as early as possible. Then you call it as assisted spontaneous breathing. And finally, once the effort is sufficient and all the breathing control comes, it becomes a fully spontaneous ventilation. So early extubation is anticipated and weaning is completed. So at the start, the patient might be fully sedated. His breathing control is not operating. He depends on control ventilation. If the sedation is subsequently reduced or his paralysis is not weaning off, a mixed ventilation is required that permits spontaneous breathing but shares the breathing load between the patient and the equipment. Once the patient has achieved independent and stable breathing but remains still weak, he requires gentle support in breathing, and the patient's breathing can be supported using spontaneous or assisted ventilation. And of course, the last one is spontaneous breathing just before extubation. So this is the basis of all the modes of mechanical ventilation. And once you understand this clearly, then whatever the newer modes have come, they are all what is called the jumbling of these three basic parameters, VC, PC, and PRVC. Okay, this is the basis that you have to remember. Is it okay? Anything else you want to know? Any questions on that? So once the basic knowledge is there, then you have to apply depending upon the clinical situation. The challenges will come only in the two ways. One is patient having a very rapid respiratory rate. Second, patient having a high airway resistance. Three, patient having a very low compliance. These are the three things will be challenging to manage. So to overcome these three challenges only, you modify your ventilatory management and give names to that accordingly. Ultimately, your aim is to deliver the tidal volume, maintain the oxygenation, and eliminate the carbon dioxide. Okay?
Yes, sir.
Right.